Good evening. Thanks for joining me tonight. I'm Dr. Peterson, and with my partner, Dr. Fuentes, we've decided to do some case presentations and create a YouTube channel. The idea behind this was to be able to share our cases and share our knowledge and help our referrals kind of understand how we practice and why we practice the way we do. The idea is to help our referring doctors think like us and to be able to communicate like us, and then it makes that transition between the handoff from the general practitioner to the periodontal provider easier transition for the patient. So what we've done is we've decided to move forward with creating a YouTube channel and doing a series of case presentations, interesting cases that we've done in our practice, some newer, some older, and just showing the scope of periodontics today. Um, a wide variety of procedures from soft tissue augmentation to hard tissue augmentation to a variety of cases that are out of the ordinary. Um, so let's move forward with tonight's presentation. So here we are, clinical presentation of a 33-year-old female referred over to our office for a periodontal defect on number 14. As you can see here, furcation radiolucency on the buccal furcation. Well, you can see where I'm pointing with my arrow. This tooth presents with no mobility. And one thing that we do when we see isolated periodontal defects to maybe one tooth is we're going to do some vitality testing. In this case, the upper left quadrant, 13, 14, and 15, all responded normal to cold. So here we are, isolated 15 millimeter probe depth on the direct buccal of number 14. Why? Why do we have this one isolated tooth? When we see these types of presentations, the first thing, a couple things come to mind. One is our endodontic involvement, which we know the answer is no, because the tooth responded normal to cold and EPT. When I get these isolated narrow defects, in the back of my mind, I'm thinking a vertical root fracture or a cracked tooth. Depending on the location of the fracture, is debatable. So, but in this instance, direct buccal furcation. So, what's our etiology? Well, we know the primary etiology for all periodontal diseases, and from gingivitis to stage 4 grade C periodontal disease, is going to be bacterial plaque and then the host immune response. But in this case, there's underlying predisposing factors, specifically when it comes to furcation involvement. There can be root anatomy and concavities, enamel pearls, cervical projections. Some studies talk about accessory pulpal canals, even intermediate bifurcation ridges. All these factors can be localized tooth factors that start the periodontal disease progression. And then once the disease progression has made its way into the furcation where it's challenging to clean and maintain long-term, that's where you see advanced disease progression that can happen rather quickly. So being a general dentist for 3 years before going back to school and becoming a periodontist, I looked at teeth differently as a general dentist than I do as a periodontist. I think that's key for our referrals. Several different systems to consider dating back to the 50s. The two main systems are going to be McGuire and Nunn, or Kwok and Caton. McGuire and Nunn talk about tooth-specific factors in terms of periodontal prognosis, where the reason why I like Kwok and Caton is it's a classification system based on the ability to control disease. They have 4 different categories: favorable, questionable, unfavorable, and hopeless. When I look at this tooth as a general dentist, I'd say it's hopeless. Take it out. But when I look at it as a periodontist, I find this tooth favorable for a variety of reasons. Looking at this tooth, and we'll dive into this case in a little bit more detail. The tooth is not mobile, which is going to be one of the biggest prognostic factors that Kwok and Caton talk about. um, in terms of long-term prognosis and long-term tooth stability. Um, the parafunctional habits, so grinding, we can adjust the occlusion to stabilize the tooth. And the other factor they talk about is smoking in the 2007 study, all of which can be controlled for. So when I see this tooth as a periodontist, yes, there's an isolated deep periodontal defect on the direct buccal of 14, but all the factors, in my opinion, can be controlled, assuming it's not a vertical root fracture. So when I look at this tooth, I think it has a favorable prognosis. Also, when I look at prognosis in terms of treatment modalities, we look at defects. Is it a broad, shallow defect, or is it an isolated, narrow defect? Isolated, narrow defects have very good regenerative potential compared to wide, shallow defects. So these are all factors to consider, but I look at the tooth as a periodontist, and I think it has a favorable long-term prognosis based on disease progression. So what's our diagnosis? A lot of questions come about with the new classification system for diagnosis of periodontal disease. When I look at this tooth with the 1999 classification system, localized severe chronic periodontitis. When I look at it with the updated classification system for 2017, some may argue that it's not localized stage 3 grade C. The reason why I classified this diagnosis for this specific stage and grade, yes, the bone loss extends from the middle third of the root and beyond. However, the patient has less than 4 teeth that have been lost due to periodontal disease. There is a probe depths are greater than 6 millimeters on one tooth, isolated grade 2 furcation on the direct buccal of number 14. But why not stage 4 grade C? Well, she's lost in their classification system. Both grade stage 3 and stage 4 have clinical attachment loss greater than 5 millimeters, which we do have. But there's no secondary occlusal trauma, no masticatory dysfunction, and the amount of tooth loss, they talk about 5 teeth or more. So because it's a localized event and a localized diagnosis, that's why I've staged this as stage 3, grade C. Treatment plan. What are we going to do? Are we just going to take out this tooth and extract it and do site development for implant placement in the future? Immediate implant placement based on the furcation and the bone loss? Where is our sinus floor proximity? Is there periapical pathology? A lot of factors to consider. So we need to see. We need to be able to visualize what's going on and why this isolated defect is present on this one tooth. If a fracture is present, which I'm assuming I will find, I'm going to do site development for implant placement based on the limited interseptal bone to engage that immediate implant into and sinus floor proximity. If there's no fracture present, a couple different things that we can do. We can do true guided tissue regeneration with bone grafting material and a barrier membrane, or we can use the Lannat protocol with flap reflection, which is not the true Lannat protocol, but I'll dive into this once we see some photos about why I decided to do flap reflection specifically in this case. I'm going to move my video here a little bit. So here we are. An isolated moat-like defect on the direct buccal number 14. With this defect, it's a contained 3-wall defect. One thing to take note of in this photo is you can see the heavy wear on the occlusion of number 14, especially on the mesial lingual and distal lingual cusps, indicative of non-working interferences. We have a long root trunk length. Typically, when you see these moat-like defects, more often than not, they're occlusion related. So again, when it goes back to prognosis, we talk about the ability to control the etiologic factor, which in this case, occlusal adjustment will take care of that. So the main reason for flap reflection is twofold. Root preparation. We need to flatten and plane the root surface with a rough diamond burr to allow for epithelial attachment. And two, I need to get into this furcation and flute this furcation to allow for biologic reshaping and biologic healing. With these bulbous root forms, healing does not occur naturally, which is part of the reason why this defect developed in the first place. So by flattening out the root surface and fluting the roof of the furcation, which is difficult to see from this view, we have aided in the healing process. So treatment plans. Well, we didn't find an isolated narrow defect suggesting a vertical root fracture. So we've now moved our decision making from extraction and site development to regeneration. So in our office, we traditionally use the LANAP protocol for true osseous regeneration. What does this look like and how does it work? Well, it's a pretty complex process, but what we end up doing is we create a laser stimulated blood clot that allows for scaffolding and live stem cells for true periodontal regeneration. Regeneration works well when we have deep isolated defects, such as this case, a well-contained 3-wall moat-like defect. So this does not follow the LANAP protocol due to flap reflection, but the reason for flap reflection was one, to transilluminate to rule out vertical root fracture, and for root preparation and biomodification. I can't do that in a closed procedure. Blood clot stimulation and removal of the diseased epithelium and the bacterial invasion, all part of the LANAP protocol, was followed. The one thing that I really took away from my LANAP training, one is the etiology, and two, occlusion. Occlusion. I can't reiterate it enough. Heavy occlusal adjustment. If we don't control for the occlusion, this blood clot, which we want to be stable during the healing phase, can have micro movements. The blood clot will break down. When the blood clot breaks down, we lose regenerative potential. So control for the etiology. I can't say it enough. Heavy occlusal adjustment, in this case, light centric only. We removed all lateral interferences on this tooth, and this is going to allow for stability during the healing process. So here it is. Flap is closed, occlusal adjustment, and a laser stimulated blood clot. We will follow up with this case to see the wound healing. Typically, it takes 6 to 12 months for true periodontal regeneration to see radiographic changes and osseous growth. But I really appreciate you guys tuning in tonight to watch this video and learn with us. So thank you very much and have a good night. Thank you.